Well, this is Dr. Zunick speaking, and I'll let Kim speak in a little bit just to share a little bit more about her practice site. So I changed the title a little bit here because, and I'll explain in a few more slides, that pharmacist clinicians is a title that we use within the state of New Mexico, but across Indian Health and actually in other agencies within the Department of Health and Human Services, we have clinical pharmacists providing great care, and so didn't want to leave them out just by the nomenclature. I work in Albuquerque currently. I am full-time in the primary care clinic, and I provide chronic care management for the patients that we see here. So patients are actually scheduled in an appointment with me, and they may come to me for diabetes and related risk factors for cardiovascular disease, but I also see a lot of other chronic care conditions. We also have another pharmacist clinician that works here in our clinic, and his name is Dr. Jason Harris. And so our site just really wanted to make sure that we could protect the time of pharmacist clinicians and decided to hire us full-time under the med staff. But many clinical pharmacists work in many types of varieties of environments where maybe they work within the pharmacy and then take turns rotating either into clinic or providing their services in pharmacy-based practices. So that's a little bit about me. I'm going to let Kim introduce herself and a little bit more about where she practices at.
Good afternoon, everyone. Here at the Phoenix Indian Medical Center, I'm the co-director for our cardiovascular risk reduction clinic, managing hypertension and hyperlipidemia to our referred patients. This clinic actually started out as my residency project many, many years ago, and I'm happy to see that it's kind of lasted throughout the years. In addition to working in our cardiovascular clinic, I also work in some of our other pharmacy-based clinics that we have here on campus, including anticoagulation, immunization, tobacco cessation, and latent tuberculosis. So I do get to see patients in multiple clinics here. One of the other things that I wanted to share is that Dr. Zunick and I are also faculty members for the Arizona Pharmacy Association, teaching the American Pharmacists Association Cardiovascular Risk Management Certificate Program. And we've been doing that now since 2016. And so we've met lots of different pharmacists across different backgrounds, and it's always a real pleasure to be a part of that program also.
All right, so I want to encourage those pharmacists that are dialing into the call that sometimes change can come slowly and sometimes for a good reason. When we look at the background of clinical pharmacists within Indian Health, you can see from this slide here that this all started in 1996, which seems like a really long time ago. It was actually before I graduated from pharmacy school. I graduated from the University of Arizona in 2000 and didn't realize that this was in place, but it was a memo that was written by Dr. Trujillo, and he was the Assistant Surgeon General, and it was dated October 18th, 1996, and he basically designated pharmacists as primary care providers to allow for some privileges that include prescriptive authority. And so leading upon that, the National Clinical Pharmacy Specialist Committee was established in 1997, and they were trying to help these different clinical pharmacists to have a uniform level of competency. And I know some of you might be at a site where you're trying to get your pharmacy-based clinic up and going, and sometimes it whacks and wings. I've had that same experience being in Indian Health since 2000 when I started out and did my residency at Phoenix Indian Medical Center. So be patient. Be creative, work as a team, keep trying even when it doesn't seem like it's coming together, because the patients definitely need us on their care team. And hopefully by the end of this presentation, you'll have ideas, and others of you that are not pharmacists will realize how we fit within the care team and can really help out the care. Within this memo that Dr. Trujillo had signed, he talked about pharmacists being a type of physician extender and even talked about a credentialing and privileging process, which is interesting because now, that's language you might hear more commonly about having pharmacists credentialed and privileged, because it just shows the level of competency that they bring and then the services that they're allowed to provide. There are lots of pharmacists within the different agencies that can apply for certification with the National Clinical Pharmacy Specialist. Basically, your application is reflecting work that's already being done locally within the clinic. If you're not familiar with the NCPS, their website link is located at the end of the slides there, so you can take a look at that. They have the forms there and the members of the committee if you have questions further. So I did mention at the beginning of the presentation that there's similar nomenclature to describe the role of clinical pharmacists. And I do want to encourage some of the pharmacists that are out there that maybe are not working in a clinic or providing a pharmacy-based service. You know, there's a lot of things that we learn when we're in pharmacy school. So even working within the outpatient pharmacy, we're using our clinical skills, but just in a different environment. And so that we're not trying to minimize that, but we're also trying to express and share how clinical pharmacists can work on the care teams as well. So I mentioned earlier the credentialing and privileging process. I do know the NCPS committee is working on some templates that individuals might use at their site for applying for credentialing and privileging. I mentioned earlier that here in Albuquerque, we were the first pharmacist clinicians to be hired, and so we just used our med staff application and crossed out a lot of stuff that didn't apply to us. This here is just a screenshot of what UNM lists. It basically says the qualifications for working as a pharmacist clinician. And in the state of New Mexico, we have a separate license that we actually have to apply for and show that we have a level of competency. And then the privileges just say what are the services you're going to provide within your clinic setting. Along with that, clinical pharmacists usually have collaborative practice agreements, and so this is just the first couple pages of ours that we use here. Jason's name is included on here. The screenshot I'm showing just shows my name. But basically, it has an agreement that you have with a supervising physician, and it's approved by the clinical director that says, this is the services you're going to provide within our facility, and we're going to allow the services to be provided for the patients that we're providing care for here. So if you need an example of how to put your own together, I know the NCPS website has some examples. You're welcome to contact myself or Kim if you want an example of one so that you can put your own protocol together. But it guides and kind of provides those boundaries of what care do you provide, what do you do when the patient shows up with conditions outside those boundaries, or maybe there's vitals that are not normal, and how do you go about handling those acute changes. So we already talked about that we work in unique practice environments. There's lots of ways to set up these collaborations. Hopefully you evaluate your community and the clinic needs, and that can guide what you decide to set up. I know the NCPS is very much helping to push along not having these silos where maybe in the past clinical pharmacists might have provided anticoagulation or tobacco cessation by itself or immunizations, and now they're really wanting us to recognize that a lot of our patients, one, don't have time to come to a lot of different separate visits, but two, they don't come to us with one condition. And so maybe we might prioritize which conditions we work on during a clinic visit, but we can provide care to more than one condition. So here's a question that just kind of is out there for you, and you might think about what your answer might be. The types of services, and I think it's a polling, yeah, it is a polling question. So if you have a computer in front of you, you might choose one of these answers. So the question says, the types of services a clinical pharmacist might provide include, A says administering immunizations, starting and adjusting or discontinuing diabetes meds. B is foot exams. C is ordering and evaluating labs. D is physical examination, and E is all of the above. And right now, for those that have voted, we have about maybe 40-some people that have voted, and I know we have 119 participants on the call, so if we just do a couple more seconds. And the majority are choosing all of the above, and that is correct. We actually can provide a wide variety of clinical services, and some may not do all of the options listed here. Some might do extra, but this is just an example to help you see that pharmacists do quite a bit more than just, filling the prescriptions and counseling the patient. There's actually a lot more that we can provide for our patients. Okay, so here I'm going to just talk briefly. This is a graphic that hopefully helps you think about, what are the roles of these clinical pharmacists. And so I have these red bubbles that are kind of, the main catchphrases for us. And so on the top, it talks about medication reconciliation. That basically says we're talking to the patient, what's their complete med list, including over-the-counter and prescriptions that they get outside of the Indian Health Service pharmacy. Maybe they go to another pharmacy. For us here in Albuquerque, they might be going to Walgreens or another retail facility. But we're basically saying what all are they taking and how are they taking it. That's really important because there's a lot of times that we'll find that how something is prescribed is not exactly how the patient is taking the prescription. The second bubble to the right there is chronic disease management. And by that I mean that we have that prescriptive authority to manage things like asthma or in a heart failure clinic. Another example can be like what we're talking about today with diabetes and associated cardiovascular risk factors. Some places do a Hep C clinic. So there's lots of ways that pharmacists provide chronic disease care. A lot of times we'll do consultation and referrals. And by that I mean members on the team have questions for us like, they might present a patient scenario and ask what should we do for this patient. And we can offer them some ideas based upon knowing the medications the way that we do. We also refer to other team members. As patients come to us and need care, we're recognizing, at least in my practice setting, that there are times they're due for a mammogram and I can put that referral in. Or if they're newly diagnosed, I can take advantage of our diabetes program and utilize the expertise that our diabetes educators and dietitians have. Sometimes those referrals are just continuing outside visits, like when they're due for a cardiology follow-up. The next bubble is medication therapy management, and that is kind of known as looking at the complete med list, sort of like medication reconciliation. You have a lot more information, like knowing when certain labs might be due for monitoring, and so you provide a recommended plan of care, but maybe not necessarily you're not using any prescriptive authority, but you're printing out some recommendations that a patient can take back to their provider and share with them, or that could be faxed over to their primary care provider. We do provide immunizations, and within all of this, we have those phrases that I put in turquoise that say we're coaches. We use motivational interviewing to make sure that we're helping our patients reach their goals. We do provide education. I know for myself with the clinic visits that I have a limited amount of time, and so I do try to provide education where I can, but especially for diabetes, my go-to when those patients are willing to are the diabetes educators who can spend much more time and look more globally at the overall diabetes care. I want to spend just a couple seconds on that role of detective and help explain that a little further. So I had a patient whose wife used to work overnight at Walmart, and she had recently quit her job, and they came for a follow-up visit, and she's now home and able to cook dinner regularly, and they eat together. And his A1C had gone up, and we're trying to figure out, okay, what can we make in terms of changes to help his A1C better be controlled? And as I'm talking to him and he's sharing his story, I was reminded that he was only using his Novolog for breakfast and lunch. And the reason was that dinner time really was not something that they would do since his wife had been working, and he would just have a snack. So there was no Novolog used for dinner time. Well, now that his wife quit her job, they were having dinner and very good dinners, and so we realized we needed to put back in that Novolog. And so some of that just comes by talking to the patient, getting to know them well, learning their story, and then that really helps as we try to help them with their diabetes management. Okay, so when we talk about how do we get these patient visits to the clinical pharmacist, it varies by site. Some referrals might come from other diabetes programs or other existing programs. Maybe the primary care provider fills out a referral. Here in Albuquerque, we don't use referrals. We basically, a lot of times the patients will call. If they can't get in to see their primary care provider, they're scheduled with us, and they're put into the slots. And so there's pros and cons of using a referral and not using a referral. The pros of using a referral, you can really hone into what does the primary care provider want you to help this patient with. In terms of cons, sometimes I get some patients that are not appropriate in my clinic, meaning that they're much more complex or complicated. Maybe they have a lot of acute care conditions going on. Although that does happen rarely, those are patients that I need to tag one of the providers in clinic and say, I need help with this patient. I need to, have you help me see this patient because I can only do a certain part of the care for that visit and not the acute conditions that are going on at that time. So here's a screenshot of an EHR consult. And I know within Phoenix they use these referrals. And so you probably can't read it very well, but this is to show you that it's possible to set up your referral and to be able to even to designate within it what exactly the provider wants the pharmacist to focus on during that clinic visit. And then it just can pop up either as a notification or it can be printed out to a printer, and then the patient can be scheduled for an appointment after that or even sometimes before that. So there's ways to basically have them within the system and referred. So before Kim does a little part of her section, I'm going to finish up with this slide here that just basically talks about, we're a member of the care team and we can provide a lot of services. I didn't mention earlier that medication adherence is a really huge key part of what we do. We can look at barriers to taking their medications. Some people are really good at getting their medications filled regularly, but they're not actually taking it. And so if you have that rapport with them, you can actually talk with them and say, okay, how are you taking this? And if you're realizing that, they're sharing some ambivalence or they're actually not taking it, you can try to problem solve with them and figure out how you can help them to become more adherent. We are one of the most trusted healthcare professionals, and so that really helps as we provide care to the patients, but we're also a really important part of the care team in terms of when we go to pharmacy school. That's the hugest part of our learning is really around all those medications, and so we really are the experts with that. And I didn't realize that as much until I started working in clinic more and was able to see how I was able to help the other providers that are providing care to patients. And I think Kim's going to take over for a few slides next.
Thank you. So Mary Jo has done a great job with talking about the role that clinical pharmacists can play in the healthcare team. Now I want to switch gears just for a little bit to actually look at a case and see what a typical patient would look like that some pharmacists may encounter in clinic. So this patient, she's ML. She's a 62-year-old grandmother who was recently diagnosed with hypertension and type 2 diabetes. But today in clinic, her blood pressure is 162/108, and her A1C is 11.3. She reports that she's not a smoker, but she does occasionally participate in her tribe's ceremonies that involve tobacco. She's the primary caregiver for her two grandchildren, ages 9 and 12, and she reports that she's not able to help the children most times with homework as she only went up to school to the 7th grade. So that kind of already gives us a little bit of information about her health literacy. Most of her income comes from making and selling jewelry at fairs, so she travels around quite a bit when she can get help with the children. Because her blood pressure was so high today, we wanted to make sure we do a review of systems and make sure we can rule out any potential harm from hypertensive urgency or hypertensive emergency. And so today she does not have any headache or any vision changes, no chest pain, and no shortness of breath. So we have some labs back on her, and with her lipid panel, her total cholesterol slightly elevated. Total cholesterol is 232 with an LDL of 164. Her liver enzymes are pretty much within normal limits, and her serum creatinine is 0.7. She doesn't have any other significant past medical history. She does have a strong family history of cardiovascular disease. Her mother had a stroke at age 55, and her father had a heart attack at age 51. Her BMI today is 38, and she has an ASCVD 10-year risk of 17%, and she has no drug allergies. So I know as I was reading this case, I could probably hear some of your wheels turning today, and you already had some ideas of how you would like to treat this patient. So let's take a quick poll of the audience to see what most people would do to treat ML's blood pressure. Okay. So it looks like most people are of the mindset that they would like to start her on lisinopril. I see some people who would like to consider her on hydrochlorothiazide monotherapy. But let's dig into this a little bit more, and we'll come back to this question a little bit later. So also thinking about her diabetes, what do you think you would consider to treat this patient's diabetes at this point? I think we should have another poll available to see what most people would think. If not, just kind of keep it in mind. Oh, there it is. So now you have the opportunity to answer the poll to see what you would do for ML's diabetes today. Looks like majority of people would like to start her out on metformin and add some lifestyle modifications. And we'll come back to that question as well. And let's move on to the next question to see how you would address her cardiovascular risk. What would you want to do for her today? You can start her on atorvastatin 80, pravastatin 40 milligrams, atorvastatin 80 milligrams plus aspirin, pravastatin 40 milligrams plus aspirin, or just lifestyle modifications with aspirin. It looks like majority of the audience is leaning towards starting her on atorvastatin plus aspirin. A few people want to start her just on pravastatin 40 milligrams plus aspirin. But we'll come back to these and talk about what we can do for this patient to help minimize her cardiovascular risk and help to optimize her outcomes from her diabetes and hypertension. So when it comes to evaluating and assessing patients for diabetes and other comorbid conditions, we don't want to just look at the patient and just treat the numbers. The American Diabetes Association Standards of Care actually recommends using a patient-centered communication style. That means that it's a person-centered and strength-based language that uses active listening and elicits patients' preferences and beliefs, assesses literacy, numeracy, and potential barriers to care that should be used to optimize patient health outcomes and health-related quality of life. So we should be looking at the objective data as well as the subjective data to help assess the patient. When we do that, we know that we can help optimize the care for the patient. It helps to minimize burden of care, reduce harm of overtreatment with giving the patient too many different medications, but it also helps to assist the clinician in making a decision on how to proceed with treating the patient. Sometimes when we hear the word patient-centered care, we automatically equate that with patient satisfaction. Even though patient-centered care can lead to patient satisfaction, they're not necessarily the same thing. Patient-centered care still involves using evidence-based medicine, and it's a shared decision-making process with the provider, the patient, and sometimes their family members. It also takes into account the patient's preferences and their cultural values. Patient satisfaction, on the other hand, is really a marketing-based concept. It involves meeting or exceeding the consumer's expectations, so in this case, that would be the patient. And it usually is related more to the delivery of the patient care. In the patient-centered model, the provider is not obligated to satisfy all demands of the patient. For example, consider a patient who really enjoys their visit with their provider, but their glycemic control worsens over time because the patient's diabetes is not being adequately addressed. The patient has excellent satisfaction with their provider, but it's not patient-centered care since the diabetes is actually not being treated. There are many other misconceptions about providing patient-centered care. One misconception that we see a lot in our population is that patients aren't interested or they're not able to talk about their care with their provider. This can be overcome with patient activation by engaging the patient more during the visit. Having a true conversation or even sharing stories in plain language about the patient's condition can give the patient the encouragement to open up about their disease state. There are several organizations that support the use of pharmacists using patient-centered care. In this model that was developed by the Joint Commission on Pharmacy Practitioners, we see in the center of the pharmacist's basic duties of collecting data, assessing the patient, developing a plan, implementing a plan, monitoring and evaluating the patient is patient-centered care. That's also coupled with providing good communication, collaborating with the team, and also documenting all of these activities. Sometimes when we see patients in clinic, we do hear lots of statements of resistance. I'm sure some of you can probably identify with the following statements from some of your patients that you've already seen in clinic. Some patients might say, I just don't see why it's a big deal. My numbers aren't that far out of range and I feel fine. It seems like every time I try to do anything, it's not enough to make a difference. I don't know what I could do that would make a difference. I take my medicine most of the time anyway, so I should be able to eat what I want. Okay, so I missed a few days, but don't make a big deal out of it. I feel fine. And I do apologize here. I see that the audio is a little staticky for some people, so please just let me know if there's anything that I need to go back and review. Pharmacists also have another tool in their toolbox to help address patients, especially when they meet these statements of resistance. Another tool that we can use is motivational interviewing. Motivational interviewing is used to facilitate the change behaviors in patients. It's just another communication strategy that incorporates strategies of understanding the patient where they are via active listening, empathy, respect, and collaboration. As you can see, motivational interviewing shares some of the same characteristics of patient-centered care. Some of the value that comes along with providing patient-centered care has been documented well in the literature. Some of the outcomes that have been shown to be improved with patient-centered care are improved quality of life, fewer hospitalizations, reduction in frequency of provider visits, and improvement in metabolic control of blood pressure, cholesterol, diet, glucose monitoring, and hemoglobin A1C. All of the things that we like to see change in our patients. So let's come back to our case again with ML, our 62-year-old grandmother. After the pharmacist has been able to use the technique of patient-centered care and motivational interviewing, we collect a little bit more information about her. We understand now that she's not taking any over-the-counter medicines, herbal medicines, or traditional medicine. She really doesn't want to take medication, but she realizes that it might make her healthier for her grandchildren. She's the primary caregiver for her parents when they had their cardiovascular events, and so she doesn't want that to happen to her and be a burden to her grandchildren. Because she does have limited literacy, she does prefer to have some visual aids with her patient education. She does want to continue to respect her tribe's traditions, and so she wants to continue participating in tobacco ceremonies. She is very adamant today that she does not want to give herself injections, and because she has a dynamic schedule with selling jewelry, she does not have regular eating habits, and she can spend hours on the road with traveling to craft fairs. All right, so let's come back again to those same questions that we discussed before and see if your answers have changed. Should be another polling question. So after all of this new information, what would you like to do to treat ML's blood pressure? Would you like to leave it and recheck it as is since the patient is 62 years old? Start her on lisinopril 10 milligrams once daily. Start her on lisinopril plus amlodipine once daily. Start her on hydrochlorothiazide 12.5 once daily, or start her on hydrochlorothiazide once daily plus losartan. All right, so I see based off the numbers here, looks like the majority of you would actually like to start this patient on 10 milligrams. I actually have a slightly different thought about this patient. The guidelines actually say that for patients who are 20/10 over their blood pressure goals, it's actually reasonable to start them on 2 antihypertensive therapies. So I would probably start this patient on lisinopril and amlodipine. With the blood pressure this high today, we want to make sure that we take action. So leaving and rechecking later is probably not a good option for this patient. And since this patient does have an active lifestyle with traveling, A diuretic may not be the best choice for her. She makes her living by selling jewelry at fairs, which she could be exposed to the sun for a significant amount of time. A drug like HCTZ may cause the patient to develop a sensitivity to the sun, so the choices with the HCTZ may not be the best for this patient. So now what would you like to do for ML's diabetes with this new data? Would you like to start her on the metformin and titrate her up and use lifestyle modifications? Or would you like to start her on insulin, glargine, 10 units daily plus lifestyle modifications? Start her on glipizide, 5 milligrams immediate release twice daily? Or start her on aspart, 5 units 3 times a day with meals plus lifestyle modifications? Or just have her on lifestyle modifications alone? Looks like most of you selected the first choice to start her on metformin, and I would agree. It's first line and weight neutral, or it can promote some weight loss for some patients, which can be beneficial for this patient who has a BMI of 38. With an A1C of 11.2, the guidelines do support the use of insulin as an initial therapy, but this patient's not quite ready to start injectable therapy at this time. Glipizide could be considered for this patient. However, she does not have regular eating schedules, so it could put her at risk for a hypoglycemic event. And with the aspart, again, this patient is not ready for injections. Lifestyle modifications is a big part of managing diabetes, but for a patient with an A1C of 11.2 at this time, it might be a little bit more challenging for her to get to her goal of less than 7 for her A1C. And what would you like to do for ML's cardiovascular risk today? Would you like to start her on atorvastatin 80 milligrams once daily, pravastatin 40 milligrams once daily, atorvastatin 80 milligrams plus aspirin, or pravastatin 40 milligrams plus aspirin, or just lifestyle modifications with aspirin therapy? Looks like most of our audience would like to start her on atorvastatin 80 milligrams plus aspirin, and I would agree with that choice too. This patient is diabetic between the age of 40 to 75 with an ASCVD score of 17%. This patient would need a high-intensity statin, which atorvastatin 80 milligrams fits that bill. Pravastatin at any dose is not considered high intensity, so we would not want to start her on the pravastatin unless we had any other significant reasons to. And there are good reasons to use pravastatin for some patients, even if they do need a high-intensity statin, including drug-drug interactions. If patients actually do like to drink significant amounts or eat grapefruit, there might be another choice, another reason to start them on pravastatin. But we don't have any of that to prevent Ms. ML from starting atorvastatin today. This patient is also between the age of 60 to 69 with a life expectancy of 10 years and an ASCVD risk score greater than 10% with no major risk for bleeding. She has a strong family history of cardiovascular events with both parents, so I think that based on current guidelines, she would be a good candidate for aspirin. Although lifestyle modifications could lower her LDL and lower her ASCVD risk score, she gets more benefit with the addition of the statin, as the statin not only affects her lipid panel, but has other pleiotropic effects such as plaque stabilization, improvement in endothelial function, and reducing inflammation that can confer additional cardiovascular protection. So hopefully you can see the benefits of using that patient-centered care and using motivational techniques to help have a more tailored approach to treating patients with their diabetes and cardiovascular disease. So now I'm going to turn it back over to Dr. Zunick for a few more slides.
All right. So we have a second case. We have ML. She comes back about a month later. In this part of the case, we're going to talk about optimizing the cardiovascular risk factors. So this slide here, basically the only two new pieces of information we have is that her blood pressure today is 140/92, and that her A1C, we checked it at a month just to see where is it trending, and it's at 10%. The rest of the information below is what we've seen before. So we have a polling question here. what cardiovascular risk factors might ML work on? And you might be familiar with there are actually modifiable and non-modifiable risk factors. Our options here are A, hypertension, B, diabetes, C, tobacco use, and D is A and C only, or E is A and B only. So work either only on hypertension and diabetes or hypertension and tobacco use. And it looks like the majority of people have chosen the hypertension and diabetes. So you guys are really paying attention, because we did point out in the beginning that she is very much wanting to honor her traditional values to use tobacco just for ceremonial reasons. And so for that reason, we wouldn't focus on trying to encourage her to quit that, but just providing her information that she may need to make that decision. So just following up, these are the medications that we actually put her on, and this is following up on the case that was just presented earlier. We have listed here the modifiable and non-modifiable risk factors. And for her, there's quite a few of these that we could actually work on with her to say, okay, how can we get her in the best cardiovascular health possible? So if we're thinking through a thought process, what might we want to work on next? We did talk about, focusing in on that blood pressure, but also that A1C and trying to see where are we at. So here's some thoughts that we might look at. Have we talked to her about possibly does she have an unhealthy diet? Her high blood cholesterol, it's too soon to check yet, but we can talk about side effects and adherence. Diabetes, what's the A1C goal? Is she using self-monitoring of blood glucose? How do those numbers look? Is she having any hypoglycemia, if at all? We already talked about that we would, respect her tobacco use for ceremonial only. We notice that her blood pressure is not controlled. If we're using a blood pressure goal of less than 130/80, why is it not controlled? And then being able to talk with her about her weight, or is she physically inactive? Do we know those pieces of information? And I present this here just as a thought process, because realistically within a clinic visit, we can't address all of them. One, we have other team members that are expertise in these areas. So we may choose to refer the patient to follow up either with a diabetes educator or the dietitian. We might use the wellness center if that's a location within your community that they may use. And that could address some of these areas that are of concern. We want to look at every visit adherence. We started her on some medications. Was it too much at one time for her, or is she having side effects that are affecting her adherence? Some examples of phrases that I use with patients is to say, some patients forget their meds. How often have you forgotten in the past week? Which is maybe easier for them to remember versus saying in the past month. I might also say some patients choose to skip their medications. How often have you done this in the past? And this might be true if they're on certain meds that they know, for example, if they're on liraglutide and it suppresses their appetite, but they want to be able to have more food because they're feasting and they choose to skip the liraglutide. We want to look at every visit about any other over-the-counter or new prescription therapy that might be added on. So we could also look at adjusting her diabetes meds based on any home monitoring or adjusting her hypertension meds. So there's lots of options here. Don't forget to ask the patient what they're interested in working on. I think sometimes we get really well-intentioned and we can develop our plan and we forget to ask the patient, what is your goal for yourself? What are you interested in working on right now? So she shares during the visit that she started pseudoephedrine for a cold she developed 3 days ago and finds it relieves her headache and congestion very well. She also shares that she's forgetting her metformin in the afternoon quite regularly. As a caregiver, she's most attentive to making sure her grandchildren and parents are doing well, and so she sometimes will forget her medications for that reason. She would like to learn more about healthier ways to cook as she wants the best for her family. And she does do walks in the evening for about 30 minutes 3 times a week. So working out this plan with ML, we talked to her about how Sudafed can raise the blood pressure, and maybe that's the reason for her hypertension today. We can offer over-the-counter saline or fluticasone for the congestion if she still has it. And then schedule her for a 1-week follow-up to recheck her blood pressure or utilize one of the other team members by scheduling a public health nurse home visit to recheck her blood pressure. We might offer to have her switch to metformin sustained release, which I tell patients is the 24-hour version of metformin. So it might help with her adherence and overall glucose control. But we also want to keep in mind to refer her to the diabetes program since she is newly diagnosed, and they can provide a lot of information to help her with her overall diabetes care. I think Kim's going to take this section over now.
Okay. So now let's look at ML 3 months later. We have some new labs on her. Looks like her cholesterol has come down a little bit at 212. LDL is down to 115. Her liver function tests still look pretty good, but this time when she comes in to see us, she does have a new complaint of muscle weakness, and she does admit to missing a few doses of her meds, and she's not testing her blood sugars regularly. Her blood pressure is improved at 142/98, and her A1C even looks better at 9.4. Her BMI has actually gone down a little bit too at 37.2, and using all of this data, her ASCVD risk calculation now is 15.4%, excuse me. In previous versions of the ASCVD calculator, you had to have a treatment-naive patient's results to use the calculator, but with the ASCVD Risk Plus calculator, you actually can enter data on a patient who's already been on a statin. So if you haven't used the Plus version of the ASCVD Risk calculator, I do recommend checking that out and becoming familiar with that. And again, she doesn't report any new drug allergies at today's visit. So after we've looked at this patient and talked to her and assessed her, we see that her blood pressure is not at goal of less than 130/80. Her diabetes is still not quite at goal at A1C of less than 7. And her LDL is not what we expected. With a high-intensity statin, we expect at least a 50% reduction in LDL for patients. However, we did not see that in this patient. It only went down to 164 in 3 months. She also did experience some muscle weakness while on this medication. She did report that she does not have a pill box, and it's really too many pills for her to remember. She's lost some weight, but she's still not quite sure of what foods to eat and provide for her family. So when it comes to setting goals for these patients, it's not a one-size-fits-all approach. Even starting with how we monitor blood sugars in diabetes can be an individualized approach. Self-monitoring of blood sugars is highly recommended for type 1 and insulin-dependent diabetic patients. There's specific recommendations on when the patient should test their blood sugars. But the evidence is not as strong for patients who are not on insulin. There are some studies that show that these patients actually improve just by making them aware of their glucose levels, and their A1C can actually drop from about 0.25 to 0.3%. So we would like to talk a little bit more and explore the options of why ML does not test her blood sugars regularly. So this also brings into question if we should actually adjust her A1C goal. For most patients, their A1C target is less than 7 per the ADA standards, and there's some even tighter goals per other guidelines. But the ADA does allow for some flexibility with setting an A1C of less than 8. This may be acceptable for certain types of patients who have a history of severe hypoglycemia, limited life expectancy, advanced micro and macrovascular complications, extensive comorbid conditions, or long-standing diabetes when it's difficult to achieve their goal with diabetes self-management education, glucose monitoring, and multiple agents including insulin. When it comes to treating her hypertension, there's some flexibility there as far as setting a blood pressure goal. Most diabetic patients with hypertension should be treated to at least a blood pressure goal of at least 140/90. However, the lower goal of 130/80 can be considered for patients who are at high risk of cardiovascular disease, and if the blood pressure target can be achieved without putting the patient at increased harm. The ADA also makes time to note the to note that it's not only important to get the patients to their blood pressure goals, but also the timing of their medications can affect their cardiovascular risk. Patients who do not have the nocturnal dipping of their blood pressures can be found to be at a higher cardiovascular risk. So for these patients who are on multiple medications for blood pressure, it's recommended to schedule at least one of their medications at bedtime to return that normal nocturnal lowering of blood pressure. And let's take another look at ml statin dose goal. Patients should be on the maximally tolerated dose of a statin. When patients develop symptoms on statin medications, we try to keep them on the statin as much as possible and exclude all other causes for the patient's symptoms. There are several dosing strategies that we can use to help the patients get the best benefit from their statin therapy, such as lowering the dose. Although it may not be the patient's target dose, it is the dose that they can tolerate. You could also consider trying an alternative statin, such as switching from a lipophilic statin, like atorvastatin, to a hydrophilic statin, like rosuvastatin. You can also try intermittent statin dosing with once-weekly or twice-weekly dosing of statins that have longer half-lives, like the atorvastatin and the rosuvastatin. If patients still need further lowering to get to an LDL of less than 70, you can consider combination therapy with Zetia or taking advantage of the glucose-lowering effect of Welchol. PCSK9 inhibitors could also be considered in addition to statin therapy for some patients, but again, this patient is not quite ready for injections. The benefit of aspirin is clearly defined in secondary prevention, but when it comes to primary prevention, the data is not so clear. Currently, guidelines do recommend for aspirin for patients who are at high risk of cardiovascular disease and low risk of bleeding to not only lower their risk of having a cardiovascular event, but also to protect against colorectal cancer. But if you've been following the cardiovascular literature lately, you'll know that 3 major aspirin trials have really called into question the role of aspirin in primary prevention. There was the ASCEND trial that looked specifically at diabetic patients and found that the benefit of aspirin was almost equal to the risk of harm of aspirin in these patients. The ARRIVE trial that looked at non-diabetic patients failed to find a cardiovascular benefit in these patients, and the ESPRIT trial found a higher risk of all-cause mortality in elderly patients when they were treated with aspirin. It should be noted, though, that there's still some ongoing analyses of these trials. So it'll be interesting to see what they actually find out and see if we actually get a clear answer on aspirin in primary prevention. So other assessments we would probably want to do for our patient is that we want to make sure we're monitoring her renal function and her LFTs. Since she is on metformin, we also want to make sure we keep an eye on her B12 levels and monitor the CBC. We want to make sure that we review and assess for any signs and symptoms of bleeding on the aspirin. We also want to make sure she's getting her annual diabetic foot exam and eye exam. We want to monitor the progress of her other lifestyle modifications, including her weight loss. The American Diabetes Association does recommend that patients try to attain at least a 5% loss in weight, but at least 7 and greater would actually be optimal for these patients. So we can see that there are several things that we can do to help customize and make this a truly patient-centered care approach for our patients, and also using all of the tools that we have as clinical pharmacists to help make that happen for her, including the motivational interviewing. So now at this time, I'm going to turn it back over to Dr. Zunick.
Okay, we're almost done. We're going to do a couple slides and then we'll get to your questions. But as we're continuing to see this patient, ML, she does come back 3 months later, and her A1C is at 6.9. And I know I didn't mention it earlier, but I do want to encourage you, as you see your patients and you see maybe their A1C isn't at goal, as long as we're continuing to have progress, celebrate with your patients. It's a lot of hard work, and that role of coaching and encouraging them does go a long way. She's enjoyed that, or she shares that she's enjoyed what she learned through the diabetes program. Her family's benefiting from her nutritional changes, and she herself has lost 10 pounds. Her blood pressure today is at goal, and during your chart review, you find that the most recent labs, her protein assessment, which looks at the kidney function. The UACR last 4 months ago was 157.7. Her complete metabolic panel is within normal limits, and her lipids, which were last checked 3 months ago when the LDL was 115. We have not had a diabetes foot exam yet, and her other standards of care have been met and taken care of for the past year. Her immunizations are up to date except for a flu shot, and her last primary care provider visit was 5 months ago, and she's due for a return now. So as a clinical pharmacist, this is the thought process that when we meet with a patient, it's not just honed into looking at the blood sugar, but what are those other things that we can help the team out, that we can help the patient out? And so this is kind of an example of that here. So what could we do to take care of her? We could repeat that protein assessment. You might know from the standards of care that when we have any value for the UACR that's above 30, it's best to repeat that test again, maybe around 4 to 6 months later. And if it's persistently elevated, then the patient is said to have proteinuria. She is on lisinopril, which will be protecting the kidneys, but if there is some room to maximize that dose and not cause your hypotension, we want to do that. We can reassess her lipids, and right now the guidelines don't recommend chasing down the LDL, but we can see, just like Dr. Langley pointed out, that we can see, are we getting that expected lowering of the LDL that we should from the statin? We can do a foot exam for her today and refer her to a podiatrist for ongoing care. We can help schedule and remind her to see her primary care provider as a follow-up. Again, we look at adherence and ask the patient, what goals do you want to maintain? You've done a great job. What are some new ones that you might want to take on? And we want to continue to encourage her progress. So in summary, hopefully you see that clinical pharmacists are a valuable resource to the patient care team. The services that we provide might extend beyond filling the patient's prescription and providing medication reconciliation. And you might think of ways that your clinic might begin to incorporate clinical pharmacists if they're not already. And if you do have clinical pharmacists, hopefully you're more likely to seek them out and use them for the patients that you provide care for. So I think that's the end of our presentation, and I can do the questions unless Jen wanted to do some closeout information first.
No, thanks, Dr. Zunick and Dr. Langley. We really appreciate your presentation. If you want to go ahead and take those questions for a couple minutes, that would be great. We have them listed there for you. Can you see those?
Yes. And so I'll probably take the first two, and maybe Dr. Langley might do the last two just to split them up. So the first question, if clinical pharmacists are considered primary care providers, do patients need to have another provider for their care, or will that cover the entire spectrum of their care? That's a really good question. We are trained very differently from MDs, nurse practitioners, PAs, and so we don't replace the care that they can provide. We're very much complementary, and so as was mentioned earlier, we're a type of physician extender, and a lot of times our patients get confused by us. They're not quite sure, like, how are you different from the primary care provider? And I explain to them that they're trained differently. They're trained to diagnose. They're their main provider of care, and I'm there mainly to help focus and hone in on certain things to help them overall. So it's good that we help our patients, but we definitely don't replace the primary care provider. The second question, what training is provided for clinical pharmacists for physical assessments? How are they prepared to perform physical exams and identify abnormalities? Very good question. So a lot of the pharmacy schools now already provide physical assessment as part of their courses, and I know mine did when I graduated in 2000. So the years leading up to that, we had those courses and we got to practice on each other. I did a refresher course through New Mexico Pharmacist Association, and they provide it there, and then you actually get to work with an individual who's pretending to be a patient. And it's really just that practice that helps you identify abnormalities. A lot of times, even if I may not be able to specifically say what that abnormality is, but I know it's not a normal result, I can go and talk to my care team members because I'm right in the same hallway with them and say, can you come take a look in this ear? It doesn't look right. Or I'm hearing something maybe when I'm listening to the heart, and it doesn't sound right. I need you to come help me with this right now. And I think Kim can take the next couple questions.
So the next question, does the collaborative physician have to sign off on patient chart notes and our clinical pharmacists considered independent providers practicing under their own license. So for the physician having to sign off on the chart notes, in the way that our collaborative practice agreement is set up, they do not, but other collaborative practice agreements may be set up so that the physician does have to review all of the notes. We do have a peer review process where in my clinic we actually have 3 other pharmacists who work in our clinic, and so we do chart reviews and do the peer review process between us. If there's anything that was significant about a patient's visit that's concerning or something that's really outside of the scope of what our collaborative practice agreement actually covers, we definitely want to keep the provider informed. And so usually that does involve making them a co-signer on the chart or actually just picking up the phone and calling the provider and notifying them at that time so the physician can make the decision as to whether or not they need the patient to come on in for a walk-in visit with them or if we need to bring them back in sooner for any type of other follow-up visits.
Thank Dr. Mary Jo Zunick and Dr. Kimberly Langley for a great presentation, and I want to thank Lucy Diaz for helping me co-host, and I want to thank all of you for participating today. And I'm going to invite Carmen Licavoli-Harden, the Deputy Director for the Division of Diabetes, to make some closing remarks as well. Carmen?
Thank you, Jan, and thank you, Dr. Zunick and Dr. Langley. And I echo what Jan says. Thank you all for attending. I know you all have busy schedules, so it's wonderful that you're able to attend. And I just want to say that what a valuable service this can offer to a clinic. It was an informative presentation. I learned a lot, and with the shortage, the primary care provider shortage, and the shortage of staff in clinical offices, this is definitely a resource that should be utilized more, in my opinion. Thank you for that. Thank you for the great cases that you presented and the insightful information. So with that, I want to say thank you to all and goodbye. Thank you.